my name is Dr. Andrea Downey. I'm a clinical neuropsychologist at Children's Hospital London Health Sciences Centre. And as Anne mentioned to you, I'm going to talk about specifically the learning challenges that are associated with childhood cancer. My talk is kind of divided into 5 parts. I only have 20 minutes to talk to you, so I'm providing you with a ton of information in a very short period of time. So what I've done is at the very end, I provided a whole bunch of references and resources. So if anyone's interested in learning more about this, or they want to go back and sort of review some of the concepts that I'm talking about, you'll be able to find it in that information. So first of all, I'm going to talk about the specific types of cancer treatments that put children at risk to experience learning problems. And then I'm going to talk about the most common types of learning challenges that we see in survivors of childhood cancer, and what those difficulties look like in their day-to-day activities in the classroom. I also want to spend a little bit of time talking about how these difficulties change over time, as well as provide a very brief summary of the supports that can be provided to children who've survived childhood cancer who are having difficulty in the classroom. So it's really important to note that not all survivors of childhood cancer will experience learning problems, but we do know that there are specific subsets of children who are at risk to experience learning problems. And even within these subsets who are at risk, not all children experience problems. We know that, very broadly, that there are certain treatments that are associated with learning problems. So depending on the type of treatment that a child receives, as many as 20 to 100% of children in those high-risk groups may experience difficulties in at least one skill that's important for learning. And as Anne mentioned, many survivors also experience physical disabilities. So those might be visual impairments, hearing impairments, as well as motor impairments, which can also have an impact on a child's learning. Sometimes these learning problems can lead to the need for special education services, with as many as a quarter of childhood cancer survivors requiring special education services. And sometimes it also leads to poor educational attainment. So childhood cancer survivors are at increased risk to not graduate from high school as well. As these children get older, this in turn can affect their functioning as adults. So for individuals with very severe impairments, sometimes that has an impact on their functional independence or their ability to function independently as adults. Childhood cancer survivors are 2 times more likely than the general population to be unemployed. And when they are employed, they're at risk to be working in lower skilled positions with lower salaries. So there are certain treatments. So not all children who survive childhood cancer experience learning problems, but children who receive these particular types of treatments tend to be the ones who are at increased risk. And so very broadly, so this is a ton of literature distilled into 3 tiny points. Very broadly, children who receive certain chemotherapy drugs, especially the chemotherapy drugs that children with acute lymphoblastic leukemia receive, they are at increased risk to experience learning problems. Children who undergo surgery to the brain, so those would be usually children who have a brain tumor, who require surgery to remove the brain tumor, or they require surgery for a complication associated with the brain tumor, and children who receive radiation to either the head or the whole body. Usually that would be the case again for children with leukemia or children who have a brain tumor. So these are the most high-risk sort of groups within the childhood cancer survivorship population. And it's important to remember that, so not all children go on to have learning problems. Even within these risk groups, not all outcomes are the same. So I might see 2 children who have the same treatment, one of whom may never be referred to me because of learning challenges, and the other may have significant learning challenges. And there's a whole host of reasons why we see that variability in outcome. And this slide illustrates that here. Again, this is a ton of information distilled into some little key points. Some of the factors that influence a child's learning outcome within these populations include things like disease-related factors. So those would be things like, in the case of a child with a brain tumor, the location of the tumor, the size of the tumor, those things may have an impact on a child's learning outcome. Treatment-related factors have an impact as well. So usually the higher dose of treatment that a child receives, the more likely they are to go on to have learning problems. And that's particularly the case with cranial radiation. So we know that children who receive higher doses of cranial radiation have poorer outcomes than children who receive lower doses. And we know that children who receive radiation to the whole brain versus just a small part of the brain, they tend to have poorer outcomes as well. There are also child factors that come into play when we're thinking about outcome. So we know that the age at which a child is treated plays a big role in terms of their outcome, with younger children generally having poorer outcomes. So children who are treated at a younger age generally having poorer outcomes than children who are treated when they're older. It's thought, though we don't have a lot of evidence for this yet, but it's thought that children with pre-existing learning challenges, so sometimes kids come to us with pre-existing difficulties, especially if they're diagnosed later in life. And so it's thought that that probably infers greater risk for poor outcomes in learning as they get older. And then there's factors that also play a role that sort of are part of the treatment and part of the cancer experience, like fatigue, for example. So a lot of children who are treated for brain tumors in particular, and children treated for leukemia will experience considerable fatigue during their treatment. Many children who survive brain tumors go on to experience fatigue for many years afterwards. And that obviously has a very big impact on their availability in the classroom. And then again, something that we don't have a lot of evidence for, but probably is also playing a role, are environmental factors. So as Anne mentioned, many children experience considerable absences from school. That varies hugely from child to child. And so that's, you know, probably, I see many kids, so the average age that a child with leukemia is diagnosed is usually about 3. So many of those kids miss those really important early academic readiness kinds of years, and then they're kind of thrown into grade 1 without necessarily having that sort of experience and learning how to regulate their behavior and learning, you know, the numbers and letters and to sound out the letters and all those kinds of things. So those absences play a big role. And then obviously the extent to which educational supports are provided to children also has an impact on their learning outcome. Okay. So this is not exhaustive again, but outlines some of the more common learning challenges that we see in children who have survived childhood cancer. The top 3 are probably the most common that we see, particularly in children who've received cranial radiation. So working memory is the ability to hold information in your mind while you're processing it at the same time. And it's important for virtually everything that we do in our day-to-day activities. So parents and teachers often report that children who have difficulty with working memory will have trouble following through on multi-step instructions. So they give them 3 things to do. By the time they've gone off and done the first thing, they can't remember what the second and the third thing was. They have difficulty completing any kind of task that requires processing multiple things at the same time. So like doing math procedures, a complicated math procedure where you have to, you know, sort of keep track of your math facts while you keep track of where you are on the math procedure at the same time. So kids with working memory might be working on their math facts and then forget what they were supposed to do next in the procedure. These kids are often described as forgetful as well, particularly at home, and that can be really frustrating for parents. Processing speed is also particularly common in kids who've received cranial radiation, or another way of saying that is speed of mental processing. So these kids have a lot of difficulty completing tasks in the time that they're allotted. They generally need more time to think. So when it's not that they can't process the information, it's that they just need more time to think about it. And that's both to process incoming information as well as to process their thoughts and ideas to express themselves. We also often see difficulties with attention and concentration. So this is difficulty paying attention to tasks that are boring or effortful. Because lots of parents come in and say, well, they can spend hours on their video games or playing Lego. So we're not so much worried about whether or not a child can pay attention to something that they find interesting. It's can they pay attention to something that they don't find inherently interesting. And so these kids tend to be easily distracted, and they have trouble persisting when tasks become even slightly challenging. We also see difficulties with memory and learning. So this is both difficulty learning new information and or difficulty retaining information. So sometimes these kids have trouble learning information even with continual repetition. So even with a lot of review, they're still learning new information, but at a much slower rate than we'd expect for their age. And then similarly, we see sometimes teachers will often say to me, you know, we went through a particular concept one day, they understood it, we came back the next day, and it was gone. And that's the trouble retaining the information over time. Troubles with executive functioning is another hallmark difficulty amongst this population. Executive functioning skills are kind of like the air traffic control system of the brain. So we need executive functioning skills for planning ahead, organizing the materials that we need to complete a task, organizing our time, mental flexibility, initiating tasks independently. This also includes emotion or behavior regulation as well. So being able to inhibit an impulsive response. So like when you see your friend playing with a particular toy and you want it, being able to stop yourself from grabbing that toy. Those are also things that these kids have a lot of difficulty with. And these skills in particular can make it very hard, especially the planning, the organization, the initiative, can make it very, difficulty with those skills can make it very, very hard for kids to function independently in classrooms. They're often the kids who really need that one-on-one prompting and support from teachers regularly. And then the kids who have trouble with behavior regulation, emotion regulation, those kids often struggle socially. We also see difficulties with fine motor and visual motor skills. This can often have a big impact, not just it has an impact on being able to do any kind of task or activity that requires fine motor manual dexterity. So some kids may need, especially little kids, they may need help tying shoelaces, doing up the zippers, you know, on their coats, that kinds of things, but also has an impact on the development of their printing and handwriting skills, which we're going to talk about in the case study, can make writing very effortful for them. And it's thought that these kind of underlying cognitive skills, so from working memory down to fine motor, that because those skills are impaired in kids who survive in the subsets of kids who are at risk to experience learning problems, in turn, they have an impact on the development of what we consider kind of more higher order skills, like learning how to express yourself in writing, and being able to understand math concepts, and as well as intellectual skills. So two of the more sort of common academic challenges in these kids are difficulties with written expression and trouble with math. Any questions before I move on? I feel like I'm bombarding you with. All right. So one really important concept that I wanted to convey to you is that it's really important to note that these learning challenges change over time. So typically, children who experience poor learning outcomes, so children who survive childhood cancer who experience poor learning outcomes, they generally grow into their difficulties. So it's sometimes the case that at the time of diagnosis, particularly in the case of a child with a brain tumor, that we might see changes in their functioning at the time of diagnosis. More often though, what we see is a pattern along this line. So this is a hypothetical illustration of what this can look like across the development of a child. So the green line here, so first of all here on the x-axis, we have the child's chronological age in years. And this is their sort of hypothetical cognitive or academic skill development, also in years. So this green line here would illustrate what would happen in a typically developing child, where their cognitive or academic skill development pretty much matches their chronological age. What often happens in children who go on to experience learning difficulties because of their treatment is we have a period here where there's the diagnosis and treatment starts. Treatment can last for anywhere from a year to 3 years. And we might see continued typical development for a number of years afterwards. But once they hit sort of a stage, usually a point in their academic development when things start to get more complex, so we're sort of around 6 years of age here where they might hit grade 1, we start to see, we start to see a little bit of a gap developing. And what happens is these kids continue to develop new skills over time. So it's not that they're regressing, it's not that they're losing any skills, it's not that they stop developing or that they plateau, it's that they are not making gains at the same rate as they would have been previously. And so what happens is a gap starts to form between where their skills are and where we expect their skills to be for their age. And this can appear anywhere from months to several years. It might not even be detected for months until several years after their diagnosis and treatment. And because of that, we generally refer to that phenomenon as neurocognitive late effects, because they happen sometimes many years after treatment has completed. So this is a really important concept because it might be the case that you may see a child, you know, who's just finished treatment for cancer and has been on treatment for 3 years and who may be doing fine in school, but that doesn't necessarily mean that as they get older and the demands increase, that will continue to be the case. I just wanted to give you, because most people are not familiar necessarily with what's involved in a neuropsychological assessment, I'm just going to go over quickly with you what that involves. So neuropsychological assessments are what I would do at the hospital. So typically when a child is having difficulty, when difficulties are identified at school, or at they are at particularly high risk to go on to have learning difficulties, like a child with a brain tumor who's receiving cranial radiation, they're referred to me for a neuropsych assessment. And this is a specialized assessment that helps parents and teachers understand how conditions that affect the development of the brain influence thinking skills that are crucial for learning. Basically what we do is we document the cognitive effects of either a disease, a type of treatment, or an injury on the brain on the various different skills that I've illustrated here surrounding this little boy here. We do this by having the child or the adolescent come to our office and they complete a number of tasks and activities that measure these skills. And not only are we looking at sort of those core cognitive and academic skills that are important for learning, but we also look at, I think the timer must be on here, we also look at their behavior and emotional well-being. So Anne and I haven't really even delved into this, but childhood cancer survivors are also at risk to experience psychosocial late effects as well, so mental health issues, social difficulties, that kind of thing. They also have a big impact on a child's academic functioning. So I look at that as well, and I also look at their adaptive functioning, or their ability to complete activities of daily living. Through this assessment and with interviews with parents, teachers, I gather medical information, I get previous assessments, I gather all the information about all of these factors that influence learning challenges, and I put it into kind of a comprehensive evaluation of thinking skills in the context of what we know about how childhood cancer has an impact on learning. So there's lots of different ways that a neuropsychological assessment can be helpful. The most obvious is, first of all, that through that assessment process, we get a better understanding of a child's cognitive and academic weaknesses, and it also allows us to identify strengths, which are also important. We use this information then to make recommendations around accommodations that can be helpful, and not just accommodations and strategies that can be used either in the classroom as well as at home. And this often assists with the development of an individual education plan if that's appropriate, and can also help parents and families access community resources. And sometimes the neuropsych assessment determines whether or not a child has a disability, or I'll sometimes make recommendations around whether or not a school board should consider formal identification as well. Other ways in which neuropsych assessment can be helpful is that it helps us to understand behavior within the context of neurocognitive difficulties. So I mentioned some of those executive functioning skills. that can affect a child's behavior, like difficulties regulating their emotions, trouble inhibiting impulsive responses. And sometimes those can be perceived as sort of just purely behavioral versus really sort of the outcome of underlying neurocognitive difficulties that make it very hard for a child to stop themselves from crying whenever they're disappointed, or to stop themselves from pushing their friend whenever they're frustrated. And so that can help kind of to sort of reframe people's perceptions about why behavior is occurring. And sometimes that makes it a little easier to manage them. It also provides an objective understanding of a child's needs because sometimes parents and teachers disagree about what a child needs. And so neuropsych assessment can help with that a little bit because it's subjective, and then can help adjust expectations. So sometimes the assessments that I've completed have meant that expectations have been adjusted in both directions. Either that we need to set higher expectations or that we need to think about modifying the curriculum. Because of our knowledge about, and this is across neuropsychology in general, but also because of our knowledge about the late effects associated with particular diseases and treatments, we can also make predictions about future areas of difficulty. And this is one of the reasons why I'm fortunate at the hospital. I do serial reassessments with the majority of children who get referred to me. So if a child's referred to me at age 4, I continue to see them semi-regularly until they turn 18. And that allows me to, to document any of those emerging difficulties that we know are likely to pop up down the road. I tend to also carry out those assessments around transition points. So usually for most of the survivors that I see, I do an assessment around the transition from elementary school to high school, and then I'll do another assessment from high school to post-secondary workplace to help with those transitions as well. Again, I've distilled this down. One of the main sort of things I think that schools find helpful about neuropsych assessments is the recommendations that I might make around interventions that could be helpful in the classroom. And we basically can boil the recommendations down to, or these interventions down to, compensatory recommendations or actual remediation. Unfortunately, a great deal of what we have available is, not unfortunately necessarily, but is compensatory. So basically ways of kind of getting around the disability, not necessarily actually trying to close that, close that gap. So remediation would result more, hopefully anyways, would result either in closing that gap or preventing that gap from getting bigger. So some of the compensatory strategies we have are basically sort of like accommodations. So for kids who have memory difficulties, we ask for reference sheets, particularly in situations where the emphasis is on testing the individual's knowledge, not their knowledge, the emphasis is testing their ability to understand the information and apply it, rather than their ability to memorize the information. For teens, I often spend time talking to them around memory strategies, so ways of learning information more efficiently. Technology is remarkable and extremely helpful for most of these kids, and the earlier it can be started, the better, because I find if kids get really used to using technology as early as grade 3, grade 4, they're comfortable using it by the time they get to high school, and that's really, really when it matters. I talk to kids about, using their iPhones and all the various different apps that are available to help with organization and planning and time management, more the teenagers for those sorts of things. We often ask for extra time for kids with processing speed difficulties, and for younger kids who have handwriting difficulties, we often ask for their oral, what they would normally provide in writing to be scribed for them, although that's very resource heavy. Sometimes we consider program modifications, so where the curriculum expectations are modified. And there are some medications that are available. So children with leukemia, particularly who have difficulties with attention, do benefit from methylphenidate or Ritalin to improve their attention. And there are some medications available to help brain tumor survivors better manage fatigue as well. So we have less under the remediation category. So there's variable access within, so our catchment area is massive at the hospital. It goes down to Windsor, up to Owen Sound, up to Kitchener, Thunder Bay, yeah. So we're dealing with a huge number of different school boards, and there is massive variability within school boards in terms of what's available in terms of actually providing remediation. And even within school boards, there's a lot of variability. So here in the Thames Valley District School Board, they've invested in a program called Empower, which is a reading remediation program that was developed by a group of researchers at the Hospital for Sick Children. And it shows some promise as being a good reading remediation program, but it's even not available in all of the schools in the Thames Valley Board. What I used to often suggest to families, and I still will sometimes, is private tutoring. However, private tutoring is cost prohibitive for most families. Most families don't have the resources to pay for a private tutor, nor do they have the resources to seek out and find tutors as well. And so what Anne and I are particularly excited about that we've been able to offer to families, and before we really had nothing to offer them, is the Childcan volunteer tutoring program. So now when I identify that a child is really struggling in reading, math, writing difficulties, needing some help keeping up with workload demands on entry to high school, I'm able to refer them to Jackie, and she does an amazing job of seeking out tutors and helping kids. And I have to say, from my point of view, it's almost a relief to be able to say to families, there is this one thing that we can offer you to try to prevent that gap from getting bigger. So that is my piece, and I think Anne and I were going to talk about a case example.
Okay, so let me tell you about, well, we'll call her Chloe. She was diagnosed with leukemia when she was 4, and as Andrew said, a lot of kids are diagnosed with acute lymphoblastic leukemia around sort of between 2 and 5, really. Yeah. Just right after she started junior kindergarten. And this treatment involves, for girls, about 2 to 2.5 years of treatment. And in her case, she was on a protocol where that first 10 months or so was pretty intense. And then it got easier, and she was able to attend school a little more on. She had more absences than most, though. No real issues before treatment. And they lived a couple hours from the treatment center with her parents and siblings. So we're going to go through this grade by grade. So in junior kindergarten, like I said, she was very unwell. Lots of admissions for infections. It was kind of as if she'd read the side effect book and decided to have them all. And really that year, the goals of school were primarily social. She went when she could, often with her parents, part days here and there. Initially, there was some acting out at school from the brother. As often happens at the very beginning, sometimes both parents will come to London, and the children actually stay for the first month if they're farther away than an hour for this treatment. And he was in the care of grandparents at home. It always takes a little time before parents can really talk to their kids about what's happening because they're trying to figure it out themselves, and it came out at school. So, small rural school, nice sense of community. Rumors were flying like crazy. So the principal, with the parent and with me, we came up with a letter that could go out that could just kind of explain things early on about what was going on, just to get some information out and calm that down a little. They called in the school social worker just to check in with the brother and have some strategies. One we often use for siblings is just a place they can go if they're getting overwhelmed, a person that they can go to if they need a little bit of support. Before she came back to school, there was a transition planning meeting. And when I work with classmates of this age, I do classroom presentations often. One thing we always do is practice for the child's return, because the little ones are incredibly kind and supportive, but they do tend to overwhelm their classmate with their enthusiasm when they come back. So we do have to practice that sometimes. This teacher was amazing, including this child in many different ways, whether it was sending pictures of the class, FaceTiming her, lots of different ways to keep her part of that community. And there's an excellent program I did not mention in the resources. I should have, called Monkey in My Chair, that involves a stuffed animal hanging out in the classroom in the place of a child when they're not there, which is, it's a great program out of the States. The teacher did try to send some learning activities, although I think in the end she was quite sick that year, so the parents did what they could with her. And this was a community that rallied around and actually did some fundraising for the family, which was great. So senior kindergarten, as you can see, she's getting there, but a little bit more than half the time overall. Same teacher. Started to have some separation anxiety after she'd been away from a school. So she'd be in, let's say she'd be in the hospital for a week and then she'd go back. She was having a little trouble separating from parents. And they were certainly noticing some fine motor skills issues. And one of the drugs these kids get is called vincristine, and it can affect their the nerves that control the muscles. Sometimes it's a short-term effect, sometimes it's a longer-term effect. So as we do every fall, we update schools. And the teacher continued to update the kids and have lots of ways of keeping connected with the child. And what they did for the separation anxiety I thought was kind of creative is they had the child come a little bit earlier, and her friend always came at the same time, and they hung out on the playground and played together, and then they would go in together. And they also, the first few days she went back, she'd only go half days, and I think it was easier for her to sort of say, okay, I'm going to be home at lunchtime. So that kind of helped with that transition. And there was an occupational therapy referral made at that time. But as anyone who's been in the school system knows, sometimes those take a while and don't provide a lot of ongoing support. So grade 1, again, our attendance is getting better. She's completing treatment in February. A lot of that absence was because of one really long admission for a whole month in November with an infection. And certainly by the end of the year, not surprisingly, her academic skills were below grade level. But really at this point, we don't know, is that just because they missed school? Is that learning problems? There's a bit of a wait and see. So again, regular contact with the parents and the teacher, updated resources, some hand washing support for the classroom, good connections with her when she was away. And she worked with a hospital teacher. There's a school in the hospital, and she wouldn't have been eligible for it until first grade. But she was able to keep up with some schoolwork while she was in the hospital. So finally in grade 2, she's getting there almost as much as most kids get to school. Still a little less. She loves school, loved her grade 2 teacher, but she's still behind in reading and writing. And I think the math was better in her case because she had a dad who was really focused on that with her. He was good at helping with math. Could we also be so lucky? And but certainly by the end of the year, we're starting to see some trouble focusing, some trouble staying on tasks, and written tasks are getting harder. And of course in grade 2, if you think about the writing requirements, there's starting to be some. So there were frequent conversation with the parent and the teacher over the course of the year. They put in some support, some reading support at school, and we referred her for a Childcan tutor. And I can't say enough about how good Jackie it is at finding tutors in places where, every child is bused to the school, basically.
Never heard of.
Yeah.
Never heard of, yeah. If you're from a small town in southwestern Ontario, try me later, I might know where it is. But, we did eventually get her a tutor in place that summer. And at that time, when she came in and we talked about it in clinic, we thought maybe it's time to refer her for assessment. Grade 3, getting to school regularly now. But the wheels are starting to fall off here. Starting to complain of stomach aches, saying she doesn't want to go to school when there's really no physical cause. There was meltdowns around homework. didn't remember what she was supposed to do. Homework was taking longer than you would expect for a child her age. The teacher certainly reported ongoing concerns with written assignments, not completing work in class, zoning out, not participating, not being as independent as you would expect a child that age to be. And we had, again, unfortunately, we have a waiting list for the assessment, so it couldn't happen right away. But we did share resources and information about some of the potential cognitive late effects. The tutor and the teacher connected to coordinate their efforts, which is always a really helpful thing. And they did develop some accommodations. And one thing that was really, really helpful at the family level was making really clear expectations and a time limit on homework. You know, so it was like, okay, 15 minutes, you work hard, and then we're done. And the teacher, and I found we can say that, but the kid has to know it's okay to not do their homework, and that's really tough for most of them, because the teacher said. And she did have an assessment that January. So I'm going to let Andrea take it over from here.
So, so she's referred to me, and I'm see her in January, and the results of the assessment are pretty similar to the sorts of difficulties that I identified previously. So she has lots of strengths. So her intellectual skills are uniformly average. Her memory and learning skills are also exactly where we'd expect them to be for her age. And she has no difficulty with either receptive or expressive language skills. On tests of academic achievement, her reading skills are age appropriate, and so her math skills. And then she also has, although our tests aren't really sort of assessing these skills, we always sort of try to include some other strengths as well. She was extremely cooperative. She tries really hard. I see that so often in a lot of these kids, that school is so hard for them, but they try so hard, are really hard workers. She was getting along well with her peers, and she was described as being very compassionate. But the assessment did identify some number of weaknesses as well. So she was experiencing considerable difficulty with written expression. She was having difficulties with those visual motor integration skills, and her printing was noted to be very limited with really poor letter formation. Her printing, what we often see, is very slow and laborious as well. She was experiencing difficulties with attention and concentration, so both in the classroom as well as at home, and attention and working memory are very closely connected. So she was also having quite a lot of difficulty with tasks that required working memory. Those executive functioning skills were also starting to be things that she was having more difficulty with. And again, as kids get older, they're expected to complete tasks that require executive functioning skills more independently, but typically we find that these individuals are just not able to do that. They don't have the skills. So that was starting to become something that was difficult for her, and she was having trouble with processing speed. Her processing speed was low as well. There were also some concerns about, ongoing concerns about her anxiety, and this is something that's not uncommon in many of the kids that I see. It can be for lots of different reasons. So sometimes there's social anxiety. Sometimes, Anne and I were just talking about this a little bit this morning, sometimes there's social anxiety. Sometimes there's stress related to school because it's so hard and they want to do well. And sometimes it's just fear, well, sometimes not, it's anxiety that we would see in typically developing children as well. So just sort of having more fears than we typically expect for their age. And sometimes it's also kind of periodic anxiety that comes along with coming into the hospital. So these kids, after they finish treatment, they come into the hospital, you know, monthly, and then every 3 months, and then every 6 months, and then and yearly. Sometimes those appointments are really anxiety-provoking for them as well. So she was experiencing a lot more of that than we typically see. So there were a number of recommendations and ideas around interventions that were made. So she was diagnosed with a learning disability specific to written expression, and I usually then make the suggestion that the school then provides a formal identification under the learning disability category of exceptionality, and I also recommended that an IEP be put in place for her. I recommended assistive technology for her with speech to text, predictive text, graphic organizers, Again, like I mentioned earlier, the sooner that kids can start being comfortable with technology, the more likely they are to succeed in the higher grades. We also recommended that she get some resource help, and what that looks like varies greatly from school to school. Because of the difficulties with processing speed, often I'll recommend oral tests. If there's tests that can be done where there's sort of short answer, or the child just sort of can respond and it can be written down for them, then that can make it a lot easier for them to get the information out in a timely manner. Or if that's not the case, then we ask for extra time. We also ask in the younger ages, particularly when they're not as fluent in the use of technology, for decreased writing demands. So instead of having them write a full page about something, then just maybe have them write half a page. But it's really quite amazing to see what kids can do once they get the technology and they become able to use the speech to text. Then you can sort of move back up to, okay, no, we're going to expect a full page from you with, you know, you're going to correct the punctuation and the grammar and all that kind of stuff. But when it takes them, you know, 3 times as long to just write a paragraph, then we sort of say, okay, maybe there's other ways that we can assess their learning. And in the interest of time, sorry, I'm going to stop because we want Jackie to talk. Yeah. So we're going to email these slides out. So if people want to have a look at them afterwards, they can. Okay, thank you.